When a kinetic impact disrupts the abdomen, a trauma surgeon has minutes to convert a chaotic, multivariable injury to a deterministic algorithmic pathway. Survival depends on making the right sequence of binary decisions. This clinical decision tree maps the first major bifurcation: blunt versus penetrating trauma. The mechanism dictates the target. In blunt trauma, the spleen is most frequently injured. In penetrating trauma, the liver is most commonly damaged, and gunshot wounds predictably perforate the small intestine. In deceleration injuries, such as a severe car crash, the physical forces are brutal. The internal viscera are violently compressed between the abdominal wall and the vertebral column, leading to organ tears. But regardless of the exact organ injured, the entire algorithm hinges on two bedside questions. Is the patient hemodynamically stable, and is there evidence of peritonitis? Positive answers to those questions dictate immediate action. Hemodynamic instability with suspected bleeding, generalized peritonitis, omental evisceration, or bile-stained wounds strictly mandate an immediate midline laparotomy. There is also a strict physical rule for penetrating trauma. An impaled object must never be removed in the emergency room. That object may be actively tamponading a major vessel, and pulling it out can trigger catastrophic, uncontrollable hemorrhage. In those critical first golden minutes, identifying the exact anatomical injury is secondary. The patient's mechanism of injury and hemodynamic status dictate the singular choice between advancing to the operating room or proceeding to advanced imaging. To navigate the algorithm rapidly, we use precise diagnostic filters. The first is FAST, Focused Assessment with Sonography for Trauma, a rapid bedside ultrasound that detects intraperitoneal or pericardial free fluid over 100 milliliters. Its extension, eFAST, adds thoracic views across 6 total assessment areas to catch pneumo or hemothoraces. FAST is highly efficient, but we must respect its limitations. It is operator-dependent, it cannot reliably identify hollow viscous damage, and because bowel gas obscures the view, it is remarkably poor at detecting retroperitoneal injuries. The algorithmic rule for FAST is absolute. An unstable patient with blunt trauma and a positive FAST, seen as a hypoechoic fluid collection, is routed straight to an immediate midline laparotomy. If the patient is stable, the protocol shifts to the gold standard, contrast-enhanced CT. A CT scan identifies specific solid organ injury grades, quantifies hemoperitoneum, and detects arterial blush, which indicates active contrast extravasation. If a CT reveals hollow viscous injury, surgery is mandatory. When FAST is unavailable or the setting is resource-limited, surgeons rely on diagnostic peritoneal lavage, or DPL. Before inserting a needle below the umbilicus, the operator must decompress the abdomen by placing a Ryle's tube and a urinary catheter. This chart details the strict quantitative thresholds for a positive DPL that necessitate laparotomy. An initial aspiration of more than 10 milliliters of gross blood is an immediate positive. If fluid is instilled, the lavage is positive if it returns an RBC count over 100,000, a WBC count over 500, an amylase level exceeding 175, or any trace of fecal or food matter. These imaging modalities and fluid analyses act as definitive sorting gates. They separate the patients bleeding out who need immediate damage control from the stable patients whose organs can be managed, monitored, and salvaged conservatively. When surgery is indicated, the standard trauma incision is the midline laparotomy. The scalpel penetrates the skin, subcutaneous tissue, linea alba, preperitoneal fat, and finally the peritoneum. This approach offers extreme speed, minimal blood loss on entry, and wide, easily extendable exposure of the abdominal cavity. Once inside, or during imaging, the spleen requires close attention. High clinical suspicion is raised by fractures of the left 9th through 11th ribs, left lower chest bruising, and Kehr's sign, referred pain to the left shoulder caused by diaphragmatic irritation. This graphic demonstrates the exact metrics used to grade splenic trauma. Grade 1 involves a subcapsular hematoma under 10%, or a laceration under 1 centimeter. Grade 2 expands to a 10 to 50% hematoma, a 1 to 3 centimeter laceration, or an intraparenchymal hematoma under 5 centimeters. Grade 3 pushes past a 50% hematoma, a laceration over 3 centimeters, or an intraparenchymal bleed over 5 centimeters. The upper tiers are catastrophic. Grade 4 involves active bleeding, vascular injury, or hilar vessel trauma causing over 25% devascularization. Grade 5 is defined as a completely shattered spleen or major vascular disruption. Stable grade 1 and 2 injuries receive conservative management and ICU monitoring. If follow-up imaging shows a contrast blush or worsening trauma, the patient requires targeted angioembolization. Hemodynamic instability or severe high-grade injuries demand surgery, utilizing splenophraphy to preserve the organ if feasible, or a total splenectomy. Splenectomy carries immediate postoperative risks. Surgeons watch for hemorrhage, inadvertent injury to the tail of the pancreas, and the development of a pancreatic fistula producing amylase-rich drain output. Removing the spleen also alters the blood. For about 2 weeks, patients experience a rise in red blood cells, white blood cells, and platelets. If platelets exceed 10 lakh, the thrombosis risk spikes, requiring aspirin prophylaxis. Long-term peripheral smears will permanently reveal Howell-Jolly bodies and basophilic stippling. The greatest long-term threat is overwhelming post-splenectomy infection driven by encapsulated organisms, Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. Prevention requires targeted vaccines given 2 weeks prior to an elective procedure or on postoperative day 1 or 2 for emergency trauma. Additionally, left lower lobe atelectasis remains the most common respiratory complication due to splinting and pain. Because of these downstream effects, the modern trauma algorithm aggressively favors splenic preservation. Excision might solve the immediate hemorrhage, but it leaves the patient with a lifelong vulnerability to lethal hematologic and immunological cascades. Moving across the abdomen, we examine the liver, the most common solid organ injured in penetrating trauma. This diagram visualizes the escalating grades of liver trauma. Grade 1 features a hematoma under 10% and a laceration under 1 centimeter. Grade 2 covers a 10 to 50% hematoma and up to a 3 centimeter laceration. Grade 3 exceeds a 50% hematoma or a 3 centimeter laceration. Crucially, multiple injuries up to grade 3 automatically bump the overall classification up by 1 level. Grade 4 marks a 25 to 75% disruption of a hepatic lobe, involving 1 to 3 Couino segments with active bleeding. Grade 5 is a massive disruption exceeding 75% of a lobe, or a direct injury to major venous structures like the inferior vena cava or hepatic veins. Stable liver injuries are managed conservatively, but for uncontrolled hemorrhage in unstable patients, surgeons utilize this specific cross-section at the foramen of Winslow to perform the Pringle maneuver. By compressing the hepatic pedicle here for 15 to 20 minutes, the surgeon clamps off the common bile duct, the portal vein, and the hepatic artery. The Pringle maneuver is highly diagnostic. If clamping stops the bleeding, the source is within the portal triad structures. If the massive bleeding continues despite the clamp, the source is isolated to the hepatic veins. When faced with uncontrolled hepatic bleeding, surgeons divide the triangular ligaments, mobilize the liver, and pack it from above and below for 24 to 48 hours. When repairing specific structures, minor bile leaks are ligated. Major common bile duct injuries receive a T-tube repair, and portal vein injuries must be carefully repaired with Prolene suture. They are never to be ligated. In extreme liver trauma, massive rapid volume loss renders delicate vascular reconstruction impossible. The algorithm dictates blunt mechanical force, clamping and tight packing, to arrest the bleeding so the patient can survive the night. The protocol adapts for the hollow viscera. Longitudinal tears in the mesentery are repaired if blood supply holds, but transverse tears compromise vascularity and require bowel resection. Mild duodenal hematomas are managed with strict bowel rest, while frank perforations leak gas under the diaphragm and demand an omental patch repair. Pancreatic trauma prognosis is dictated entirely by the main pancreatic duct. If the duct is intact, management is conservative. If injured, body or tail trauma requires a distal pancreatectomy, while head or neck trauma requires a Becker's procedure to resect the pancreatic head while preserving the duodenum. Colorectal perforations trigger severe fecal peritonitis. These injuries strictly mandate surgical diversion, typically a colostomy or a Hartmann's procedure for sigmoid injuries, with bowel continuity restored only at a later date. This topographical map outlines the retroperitoneum, divided into 3 distinct zones. Zone 1 is central, housing the aorta, IVC, and pancreas, and carries the highest mortality. Zone 2 covers the flanks, containing the kidneys and ureters. Zone 3 encompasses the pelvic structures and is the most commonly injured area, though frequently managed conservatively. Standard ultrasound is practically useless for these zones. Stable patients receive a CT scan, An unstable patient with a suspected Zone 1 injury requires immediate angiography, followed by surgery, while an unstable Zone 2 injury is evaluated with a single-shot intravenous urogram. Hollow viscera and retroperitoneal organs hide in deep anatomical blind spots. They frequently evade initial detection on standard scans, requiring trauma teams to maintain a high index of clinical suspicion before the hidden damage manifests as catastrophic peritonitis or shock. Under normal conditions, trauma teams execute early total care. If a patient remains hemodynamically stable without hypoxia, hypercapnia, or acidosis, surgeons will perform a definitive anatomical repair within 36 hours of resuscitation. But when physiology severely deranges, that strategy is abandoned. This flowchart illustrates the descending spiral known as the lethal triad: hypothermia, acidosis, and coagulopathy. Once a patient enters this state, their blood loses the ability to clot, and prolonged surgery becomes a death sentence. At this point, the protocol shifts to damage control surgery. Phase 0 is recognizing the lethal triad in the ER. Phase 1 is a rapid, abbreviated laparotomy solely to halt active hemorrhage and quickly control any fecal contamination. The abdomen is not fully closed. Instead, a temporary Bogota bag, urobag, or laparostomy is applied. The patient then enters Phase 2, 48 to 72 hours of intense ICU resuscitation to warm the body, restore clotting factors, and correct the acidosis. Only after the physiology normalizes do they proceed to Phase 3, a planned re-laparotomy to definitively repair the anatomy and perform the final abdominal closure. Damage control surgery represents the ultimate algorithmic override. The surgeon makes a deliberate choice to leave the anatomy physically open, rescuing the core metabolic physiology from total collapse. Even with the bleeding stopped, massive burns, ascites, or severe postoperative edema can trigger abdominal compartment syndrome. The intra-abdominal pressure rises so high it physically crushes internal organ function. We estimate this pressure mechanically. A Foley catheter is inserted, 50 mL of saline instilled, and measured via manometric setup. This gauge displays the critical thresholds. An intra-abdominal pressure over 12 millimeters of mercury indicates intra-abdominal hypertension, but a sustained pressure of 20 millimeters of mercury or higher, coupled with new organ dysfunction, triggers the diagnosis of abdominal compartment syndrome. At 20 millimeters of mercury, a systemic cascade begins: renal failure, cardiovascular collapse, respiratory failure, and increased intracranial pressure. These rigid algorithmic protocols exist to keep the patient one step ahead of the lethal triad. Clinical success hinges on the surgeon's discipline to halt anatomical repair the moment metabolic physiology begins to irreversibly collapse.